The more the knowledge changes, the concepts changes, and basically the technology is going to change. So, is it that easy to change? Usually it's not. Because this is my comfort zone. Where I'm standing here, that's my comfort area. And to change this area to another one, it's not easy. And believe me, by age, it becomes more difficult. And we always rely on this. And we say, why would I bother? I'm just okay in what I'm doing. Or maybe it will not make any difference to change this concept or maybe this technology. Or maybe I would say I don't have time. Or maybe I would say that it's working good for me. So it's not easy to change. However, under the pressure and the continuous waves of knowledge and ideas, we are forced to change our concepts. We are faced in endodontics, and I would say endodontics because this is my field of interest. However, I would say in dentistry, we are faced with that fact that there's a lot of focus on the development of effective tools and materials. However, the biological basis for what we are doing doesn't take that much of interest from us. And we all end up with the idea of what works better for me, which I'm sure that all of us, we don't agree with. So let us start the story from the beginning, and we need to know that our first and main enemy, and the most difficult enemy that we are facing in dentistry, and definitely in endodontics, is microorganisms. And the oral cavity is loaded with microorganisms. More than 400 species are present there. However, we also have to know that the anaerobes, which are the bacteria which lives in absence of oxygen, they outnumber the aerobic bacteria by the ratio 10 to 1 to 100 to 1. Nair in 1990, in his classic study with his team, they come out with this conclusion, that the most decisive factor affecting the long-term outcome of endodontic treatment is the persistence of infection in root canals. So, let us start with the first challenge that we are having. Our first challenge is that we are not dealing with microorganisms as a single entity. Microorganisms do not exist as separate objects or separate cells. They do adhere together in the form of what we call biofilm. So nowadays we are talking not about bacteria, we are talking about biofilms. What's a biofilm? It's the adherence of bacteria to each other and to the surface. And in our case, the surface is the root canal dentin. And this is how they appear. This is how the root canal surface appears when it is loaded with microorganisms in cases of infection. Do bacteria play a role in the endodontic disease? Definitely yes. However, I would like to remind you that this started more than 50 years ago by the classic study by Takahashi and his team in 1965, which was published in the O journal, and they said that in the absence of bacteria, through the experiments that they have done on the germ-free animals, no dental disease occurred. This was later on repeated more than one time, and we always came out with the same result. Then came Sundquist in 1976, through his bacteriological studies on the necrotic pulps. He was doing his PhD thesis in Sweden, and he emphasized the point of the predominance of the anaerobes over the aerobic microorganisms in the endodontic disease. So, Second challenge that we are facing after the biofilm is the complex anatomy of the root canal. We are having these isthmuses, and we are having this area which cannot be reached with our mechanical instrumentation tools. More complexity, yes, all these are present in human natural teeth, and we are faced with these spaces, and we are faced with the fact that we have to clean them quite well, and later on we have to fill them with our filling materials. To make the condition even more difficult, we are faced with the third challenge. The fact that microorganisms, they do invade the dentinal tubules. Basrami et al. In 2003 have shown us these nice pictures of cross-sections in the root canal dentin, and these are the colonies of the microorganisms traveling all the way from the root canal and reaching the dentino-cemental junction. And these are hiding away from our mechanical and chemical agents. So this constitutes a very big challenge. Does the presence of the bacteria in the dentinal tubules form a problem for us? Yes, definitely. Does it affect the outcome success of our treatment? Definitely yes. So let us ask ourselves one question. Why do endodontic cases fail? They fail either pre-operatively, before starting the procedure, because we didn't achieve proper asepsis, especially in vital cases, or we fail to eliminate the existing root canal infection in non-vital cases, or maybe it fails later on after we finish our root canal treatment because we fail to seal these teeth quite well. Failure in treating vital cases, I mean infecting non-infected vital cases, comes from leakage during treatment, or maybe leakage between appointments. So you have finished the first appointment for the patient, and then between the first and the second appointment, maybe you didn't seal quite well the tooth with the temporary filling, maybe the temporary filling was leaking, maybe the tooth fractured, maybe the patient missed his appointment, maybe the patient is feeling okay, he doesn't come back. All these are the reasons that these cases are going to start leaking again. And here we have to raise a question, which is, should I go for single visit endodontics? Actually, this is not part of my scope this morning in this lecture. However, I would like to say that whenever it is possible, especially in vital cases, finish up your case in a single visit so that you wouldn't take the risk of reinfection in between visits. And all the literature supports the fact that there is no difference in the success rate between single visit and multiple visit. To make it even more appealing for you, that the post-operative pain does not differ from single visit and multiple visit. So you are presenting to the patient an easy, quick procedure, less number of appointments, and less risk for getting these root canals infected. Or maybe the canals are not very well cleaned during your treatment because basically maybe you don't have enough knowledge to know the importance of the microorganism effect on your treatment. Or maybe you did fail to identify the site of the microorganism, or maybe you didn't adopt proper measures in cleaning and shaping. So all these are going to end up that you're going to leave inside the canal behind you a lot of microorganisms, and definitely this is going to be reflected on the outcome of your treatment. Finally, you might finish up your case in the best way, and then you end up that the case is failing again. Why is it failing? Because you didn't put a lot of effort or care to the coronal seal. Again, this is not part of the scope of my presentation today. However, I would like to emphasize that there are some clinicians who would say that, which I don't agree with completely, I might agree partially. However, they would say that the coronal seal is even important than the endodontic treatment. If you seal the tooth quite well after you finish your treatment, this might not cause you any trouble, even if the root canal treatment was not properly done. I don't agree totally with what they are saying, like Professor Trop. However, I would like to say that we haven't been putting a lot of attention to the coronal seal before, but now we are talking so much about it and how important it is in preserving the root canals, which we have spent a lot of time cleaning and shaping and making them as less infected as they were before treatment. So, let's move to challenge number 4. Challenge number 4 basically is that our mechanical instrumentation is not that efficient as we think. And we are leaving behind areas of tissues which are loaded with microorganisms. So, it is not enough to depend on the mechanical instrumentation, and this was proved by some classic studies, like this classic study by Peters in 2001, in which he was testing 4 different nickel titanium instruments, and he did find out that 35% or more of the canal surface was unchanged. I want you to look very closely at this number. 1/3 of the surfaces of the dentine using any of the 4 different nickel titanium systems was untouched by the instrument. This was confirmed by multiple different studies, like this study by this group, which was published in the International Endodontic Journal, again in 2001, and they say that after balance force and lateral condensation, the oval recesses in 40% of oval canals, like the ones we are seeing here, these are what we call the recess, which is the area away from the instrument. The instrument was working here and maybe here, but it didn't touch this part. So oval canals, we have to pay a lot of attention. We need to end up with something like that. That's now the instruments are touching as much as we can from the dentine surface. I know that I'm taking things to be very much complicated, but I'm furnishing a background for what's coming later and the importance of what we are going to discuss later today. So the 5th challenge that we are facing is that root canal infections are not similar to types to any other infection in the rest of the body. Why is that? Because I don't have immunological help, because there's no blood supply in these teeth. So there's no immunological cells, there's no immunological reaction which can help me to fight this infection. And as far as I don't have blood supply, then if I'm going to give systemic antibiotics, nothing is going to change the case. I can give systemic antibiotic to change the systemic condition of the patient from being in the acute phase to the chronic phase. But does systemic antibiotics can heal endodontic infections? Definitely no. It doesn't reach the root canal. So, what should we do? How can we face these challenges? First, mechanical instrumentation, which I'm not going to touch this morning at all. I'm going to focus mostly on chemical measures. We have to adopt